Welcome to the second part of our lecture. My name is Dr. Adham and we are talking about systemic hypertension. As regards complications of systemic hypertension, blood pressure being persistently more than 140/90 damages target organs, causes what is called as named target organ damage. It causes vascular symptoms in the form of peripheral vascular disease, vascular hypertrophy and aneurysm, increases risk of developing coronary artery disease, LVH and heart failure, causes TIA, stroke, dementia, brain hemorrhage, retinopathy, renal failure and aneurysm of the renal arteries. Target organ damage can be either asymptomatic or established disease, with the following findings. Asymptomatic target organ damage, like pulse pressure in the elderly more than or equal 60 mm mercury as a sign of vasculopathy, ECG showing LVH, echocardiographic findings consistent with left ventricular hypertrophy, carotid wall thickening, ankle brachial index less than 0.9, chronic kidney disease with estimated glomerular filtration rate 30 to 60 milliliter per minute per body surface area, microalbuminuria, and established disease in the form of cerebrovascular disease like presence of ischemic strokes, cerebral hemorrhage, transient ischemic attacks, coronary artery disease like myocardial infarction, angina, myocardial revascularization with percutaneous coronary intervention, catheterization or CABG, heart failure including heart failure with preserved ejection fraction, symptomatic lower extremities peripheral arterial disease, chronic kidney disease with estimated glomerular filtration rate less than 30, advanced retinopathy. The general treatment scheme of systemic hypertension depends on presence of cardiovascular risk factors. Presence of risk factors changes the risk and the need for treatment of hypertension as follows. Patients with no risk factors and with high normal blood pressure, no intervention whatsoever is needed for blood pressure control. Patients with no risk factors and with grade 1 hypertension need only lifestyle changes for several months extending to a year. Then there is need to add blood pressure drugs targeting blood pressure less than 140/90. Same for grade 2, but for several weeks only lifestyle changes can be done. For grade 3, lifestyle changes plus immediate blood pressure drugs targeting blood pressure less than 140/90. Presence of 1 or 2 risk factors and high normal blood pressure, lifestyle changes and no blood pressure intervention. Presence of more than or equal 3 risk factors, lifestyle changes and no blood pressure intervention. And that's for all. In the presence of grade 1 hypertension, only lifestyle changes can be done for only several weeks prior to adding drug if there is 1 to 2 risk factors. In the presence of some symptomatic cardiovascular disease, chronic kidney disease more than or equal stage 4 or diabetes, or organ damage and renal failure, blood pressure and lifestyle changes are started at the time of diagnosis of grade 1 hypertension targeting a blood pressure less than 140/90. The outline of hypertension treatment is as follows. It is composed of non-pharmacological treatment, pharmacological treatment, interventional treatments, surgical treatment for secondary causes, and follow-up. The most important part and commonly not well done is the non-pharmacological treatment. It includes lifestyle modification in the form of weight reduction, better food in the form of fruits, vegetables, reducing salt in diet, low fat or essentially fat-free food, reducing stress like relaxation therapies and meditation, good exercise, smoking, cessation of smoking and alcohol, and other stress management techniques. It is recommended to restrict salt intake to 5 to 6 grams per day and moderation of alcohol consumption to no more than 20 to 30 grams per day in men and 10 to 20 in women, increasing consumption of vegetables, fruits, and low-fat dairy products, reduction of weight to body mass index of 25 and waist circumference less than 102 in men and less than 88 in women, regular exercise, at least 30 minutes of moderate dynamic exercises on 5 to 7 days per week, and advice to quit smoking and offering assistance to all smokers. Second part is the pharmacological treatment. Antihypertensive drugs act essentially by lowering blood pressure. Aim of the treatment is blood pressure, arterial blood pressure less than 140/90 mm mercury. Reduction of blood pressure by 5 to 6 mm mercury decreases risk of stroke by 40% and coronary artery disease by 15 to 20%. Prompt initiation of drug treatment is recommended with grade 2 and 3 hypertension with any level of cardiovascular risk. Sometimes in elderly hypertensive patients, drug treatment is recommended only when systolic blood pressure is more than or equal 160 mm mercury. Unless necessary evidence is later obtained, it is not recommended to initiate antihypertensive drug therapy at high normal blood pressure. Groups of antihypertensive drugs include ACE inhibitors, angiotensin II receptor antagonist, calcium channel blockers, diuretics, additional drugs like spironolactone, alpha blockers, beta blockers, renin inhibitors like aliskiren, and centrally acting drugs like alpha methyl dopa. There are some compelling indications for a group or other of drugs other than other groups. For example, in the presence of coronary artery disease, there is a compelling indication to start beta blockers for all patients with stable angina unless contraindicated, so it is the first line management. Also, ACE inhibitors or ARBs are indicated with when there is systolic heart failure. Be cautious when lowering systolic blood pressure to a goal if the diastolic blood pressure is less than or equal 60 mm mercury. In the presence of recent MI, beta blockers and ACE inhibitors, or ARBs if the ACE inhibitors are untolerated, is the first choice. In the presence of left ventricular hypertrophy, ACE inhibitors or ARBs are first line, or thiazides and thiazide-like diuretics, or long-acting calcium channel blockers. In the presence of heart failure, beta blockers together with ACE inhibitors or ARBs. Also, aldosterone antagonists may be added in patients with recent hospitalization, acute MI, elevated BMP or N-terminal pro-BMP, NIHA class 2 to 4 symptoms. In the presence of cerebrovascular disease after acute stroke, ACE inhibitors plus thiazides or thiazide-like diuretics are the first line. In the presence of diabetes with microalbuminuria, first line is ACE inhibitors or ARBs. In the presence of diabetes without microalbuminuria, ACE inhibitors or ARBs or thiazide and thiazide-like diuretics or dihydropyridine calcium channel blockers. In the presence of chronic kidney disease, the first line is ACE inhibitors or ARBs if ACE inhibitors are untolerated. In the presence of renovascular disease, thiazide diuretics or ACE inhibitors or ARBs or long-acting calcium channel blockers are first-line drugs. Interventional treatment, meaning renal artery ablation in cases of resistant hypertension with the aim of decreasing neurological supply to the renal arteries causing the renovascular hypertension. Surgical treatment for secondary cases of hypertension like stenting for renal artery stenosis, coarctation stenting, and surgical treatment of endocrinal disorders. Follow-up of arterial blood pressure is essential as hypertension is an always changing disease. Now we come to talk about another topic called resistant hypertension. Resistant hypertension is blood pressure not controlled over 2 weeks despite lifestyle measures and 3 antihypertensive agents including a diuretic. Patients whose blood pressure is controlled with 4 or more medications are considered to have resistant hypertension. It can be a true resistant or a false resistant hypertension. False resistant hypertension is as with non-compliance or with white coat syndrome, as will be discussed later in the clinical session. Management of resistant hypertension. The goal blood pressure is to be less than 140/90 in average risk hypertensive patients. Lower goal in other patients with atherosclerotic cardiovascular disease, diabetes, or chronic kidney disease. Correction of the cause is essential, including search for secondary causes of hypertension. Intensive lifestyle modification is needed. Add drugs as required. Invasive treatment should be thought of. Also, good follow-up is the key to management. Hypertensive crisis is an abrupt, marked increase in arterial blood pressure relative to the patient's baseline, with 2 components, either to be an emergency or to be an urgency. Hypertensive emergency, also called malignant hypertension, is an arterial blood pressure more than 180/110 plus symptoms and signs of end organ damage like pulmonary edema, papilledema, and encephalopathy. It's a compelling indication for ICU admission and intravenous therapies to reduce blood pressure as fast as possible. Hypertensive urgency is a blood pressure more than 180/110 without symptoms and signs of end organ damage, so oral treatment is only required and hospitalization is not essential. Parenteral medications used sometimes in the management of hypertensive crisis are vasodilators like sodium nitroprusside, nicardipine hydrochloride calcium channel blocker, clevidipine, phenoldopam, nitroglycerin, hydralazine hydrochloride. Thank you.